Infections continue to be a major cause of morbidity and mortality in cancer patients, particularly in those receiving intensive chemotherapy or undergoing hematopoietic cell transplantation. Antimicrobial agents are commonly prescribed to these populations for both treatment and prevention of infectious complications. Benchmarking studies demonstrate high antimicrobial utilization on oncology and hematopoietic cell transplant units. Antimicrobial stewardship efforts to optimize not only the selection but also dosing and duration of anti-infective therapy are extremely relevant to this particular patient population. Cancer patients are not a homogeneous group in terms of infectious risk. Patient-level factors dictate an individual's infectious risk. These include the net state of immunosuppression, the level of organ dysfunction, and pathogen exposure. The net state of immunosuppression takes into account tumor burden, neutropenia, treatment-related effects on humoral immunity, cellular immunity, and splenic function, nutritional status, and the presence of other comorbidities. Host defenses are also contingent on proper organ function. This includes intact skin, patent mucosal lumens, and intact lymphatics. When these are breached, patients can develop infections. Breaks in the skin due to vascular access devices, radiation damage, or surgical incisions can lead to central line-related infections or skin and soft tissue infections. Mucosal lumens can be affected either by chemo and/or radiation-induced inflammation, such as mucositis or typhlitis, or by tumor obstruction. Finally, lymph node dissection can lead to recurring episodes of cellulitis in the affected region. Infections arise from two types of pathogen exposure: endogenous, meaning the patient's own flora, or exogenous environmental pathogens, such as respiratory viruses. Those who have impairments in cellular immunity can also reactivate latent infections, such as Pneumocystis jirovecii, Toxoplasma gondii, or cytomegalovirus. Disease-specific risk factors also influence the infectious risk faced by oncology and hematopoietic cell transplant patients. Several common risk factors for different types of cancer diagnoses are listed in the following tables. Risk factors for infection that are shared by solid tumor patients include obstruction of bronchi, intestines, ureters, or bile ducts by tumor, local tissue injury from chemo or radiation therapy, postoperative infections, the presence of vascular access devices, and malnourishment. If neutropenia secondary to chemotherapy occurs, it is generally mild and resolves within a week. In contrast, patients with hematologic malignancies or recipients of hematopoietic cell transplantation can have significant neutropenia, varying degrees of asplenia, hypogammaglobulinemia, or T-cell defects. They have extended use of vascular access devices, frequent blood product administration, clinically significant mucositis, and more frequent prolonged anti-infective use. Autologous transplant recipients have fewer infectious complications than their allogeneic counterparts, and their infections occur when they are neutropenic. For allogeneic transplant patients, the types of infections to which they are most vulnerable can be roughly divided based upon the time elapsed from transplantation and can be visualized in this figure from the 2009 Guideline for Preventing Post-Transplant Infectious Complications by Tomblin et al. The specialized nature of oncology and transplant medicine lends itself nicely to antimicrobial stewardship programs, since healthcare providers in these fields are used to working in multidisciplinary teams. Collaborating together to create local guidelines is a simple way to get prescriber cooperation. Evidence-based infectious disease guidelines on a number of topics from the United States and Europe are available. These include, for example, the management of fever and neutropenia, the prevention of opportunistic infections in hematopoietic cell transplant recipients, and management of invasive aspergillosis. However, these should be modified within the parameters of an institution's specific patient characteristics, resources, and local epidemiologic factors. Implementing these guidelines and providing feedback to the prescribers is also essential. For example, routine antibiotic prophylaxis was not practiced before 2006 at a tertiary cancer center in New York City, but the prevention of pre-engraftment viridin streptococcal sepsis in allogeneic hematopoietic cell transplant patients was a high priority due to an incidence of 7.4% and an attributable mortality of 21%. Vancomycin-based prophylaxis was started in 2006 and was associated with complete elimination of viridin streptococcal bacteremia in a joint antimicrobial stewardship, infectious disease, and transplant service analysis. Ongoing surveillance is being conducted to follow changes in epidemiology and resistance patterns. Other key partners for antimicrobial stewardship programs include the Pharmacy and Therapeutics Committee to ensure that appropriate antimicrobial agents are available to support oncology and hematopoietic cell transplant patients, clinical pharmacists who can assist with extended interval dosing for serious gram-negative infections and therapeutic drug monitoring, the microbiology laboratory for the timely diagnosis of infections, including adoption of rapid diagnostics, and infection control to assist in analyzing the relationship between antibiotic use and trends in microbial resistance. Adoption of healthcare information technology via electronic medical records, computer order entry, and clinical decision support facilitates antimicrobial stewardship efforts by improving prescribing and reducing medication errors. Fever and neutropenia is a common problem that occurs during receipt of cytotoxic therapy for the underlying malignant disease. The 2010 Infectious Diseases Society of America guideline provides a blueprint for the antimicrobial management of febrile neutropenic patients. Adherence to these guidelines is an easy target for stewardship programs. One key point that this guideline emphasizes is a categorization of neutropenic patients into high versus low risk to determine the delivery, venue, and duration of empiric therapy. High-risk patients are anticipated to have an absolute neutrophil count less than 100 for more than 7 days after cytotoxic chemotherapy and/or have significant comorbidities such as hypotension, pneumonia, new onset abdominal pain, or neurologic symptoms. These patients should be admitted for intravenous therapy. Low-risk patients are neutropenic for less than 7 days with few or no comorbidities. They can receive initial oral or intravenous doses in a clinic or hospital and then be transitioned to outpatient oral or intravenous treatment provided they meet specific criteria. The combination of an oral quinolone and amoxicillin clavulanate is a well-studied regimen. If outpatient therapy is arranged, then vigilant observation and prompt access to medical care should be ensured 24 hours a day, 7 days a week. Patients whose clinical condition worsens should be able to reach their local medical facility within an hour. Recurrent fever or new signs of infection warrant admission and management as for high-risk patients. Stewardship programs can create an institution-specific guideline for the management of febrile neutropenic patients. In addition, because multidrug-resistant gram-negative bacteria are increasingly responsible for infections in this population, antimicrobial stewardship teams can assist prescribers in making modifications to initial empiric therapy for patients who are known to be colonized and/or have prior infection due to multidrug-resistant organisms as clinically warranted. Established stewardship strategies such as prospective audit and feedback and antimicrobial de-escalation can be effectively performed in cancer patients. While complete adherence is not likely to occur, clinical guidelines that are geared toward common infectious problems such as fever and neutropenia or management of invasive aspergillosis can improve clinical outcomes in this patient population. Finally, the disproportionate use of antifungal drugs in immunocompromised patients has also led to an emerging literature on antifungal stewardship. Several institutions have used a multi-pronged approach incorporating pre-authorization and/or prospective audit and feedback, in addition to education and guideline development to improve antifungal prescribing. In conclusion, cancer and hematopoietic cell transplant patients are important targets for antimicrobial stewardship since they are frequently exposed to prolonged courses of anti-infective agents. Antimicrobial stewardship team members should appreciate that these patients can have varying immunosuppressed states that then inform their infectious risks. Being able to assess the type and degree of immunosuppression thus requires a level of expertise by antimicrobial stewardship personnel involved in the care of cancer patients. U.S. and European guidelines are available as resources for antimicrobial stewardship teams to develop locally relevant guidelines. And finally, there is a slowly growing body of literature that shows that antimicrobial stewardship programs can effectively apply a variety of established stewardship strategies in the oncologic and hematopoietic cell transplant patient population.
In the last 20 years, the U.S. healthcare continuum has grown, encompassing many additional care settings outside of the hospital. We continue to provide care in acute care hospitals, but have expanded to ambulatory care settings, long-term acute care hospitals, long-term care settings, and the home. In this presentation, we will focus on residents in long-term care facilities. Resistant organisms are common in long-term care facilities. In one long-term care facility, 14 to 25% of residents were colonized with methicillin-resistant Staphylococcus aureus, ESBL-producing Klebsiella, ESBL-producing E. coli, or vancomycin-resistant Enterococci. Studies have shown one of the strongest predictors of developing an antibiotic-resistant infection is being a resident of a long-term care facility. In a study published in 2013, long-term care facility residents had 8 times the risk of contracting antibiotic-resistant E. coli compared with non-long-term care facility residents. The reasons for high rates of drug-resistant organisms in long-term care facilities are multifaceted, including the frequent transfer of patients with multi-drug resistant organisms from acute care hospitals to long-term care facilities, increased opportunities for horizontal transmission of drug-resistant organisms, and the widespread and often unnecessary use of antibiotics. First, patients with multi-drug resistant organisms are often too sick to go home and therefore must be discharged to long-term care. Second, there is a propensity for horizontal transmission of resistant organisms within long-term care facilities, given largely poor infection control practices and an increase in invasive devices and procedures. Today, the long-term care facility population includes more acute and subacute residents with central lines, chronic respiratory therapy, feeding tubes, dialysis, and IV antibiotics whom were previously treated in hospitals. In addition, staff in long-term care facilities have not been given appropriate education to treat these more acutely ill residents. Antimicrobials are frequently prescribed in long-term care settings. In a study from the 1980s, it was reported that at any one time, 8% of residents are on antimicrobial therapy, and each resident has a 50 to 70% likelihood of receiving at least one course of antimicrobials during a given year. Resistant organisms may also develop in the long-term care facility due to antibiotic treatment initiated in the hospital. In this study, residents who had received levofloxacin in the hospital were 1.6 times more likely to develop MRSA in the long-term care facility. If they had received a third-generation cephalosporin in the hospital, they were 2 times more likely to develop MRSA in the long-term care facility. It is estimated that 25 to 75% of the systemic antimicrobial use and 60% of topical antimicrobial use in the long-term care setting is inappropriate and suboptimal. The take-home message from this is that antibiotic exposures and infection control measures in the hospital influence the long-term care facility residents' health and vice versa. So we must make every attempt to improve antibiotic use in both the acute care setting as well as long-term care setting. It is widely accepted that antimicrobial use optimization should occur in the acute care settings, and the Joint Commission has now established criteria for a hospital's antibiotic stewardship program, programs that promote the appropriate use of antimicrobials by selecting the appropriate agent, dose, duration, and route of administration. The objectives of an antibiotic stewardship program are to optimize the utilization of antimicrobial agents in order to minimize acquired resistance, improve patient outcomes, decrease patient toxicities, and reduce treatment costs. Many acute care hospitals have developed antibiotic stewardship programs due to an increasing prevalence of healthcare-associated infections, coupled with decreased reimbursement for healthcare-associated infections and public reporting of these infections. They also recognize a lack of new antimicrobials that are in development, so having an antibiotic stewardship program is fiscally responsible. But there is limited literature to support antimicrobial use optimization in long-term care facilities. It is agreed upon that efforts are necessary to improve antimicrobial use in the long-term care setting, and the Centers for Medicare and Medicaid Services has established the development and maintenance of antibiotic stewardship programs as a condition of participation for long-term care facilities. These facilities have been slower to adopt antibiotic stewardship programs due to a lack of necessary personnel, usually no infectious diseases trained personnel at the long-term care facility, nor an on-site pharmacist, lack of funding, and a paucity of well-validated strategies specific to long-term care facilities that can be easily implemented. The clinical diagnosis of infection in this population is also imprecise. Symptoms are often not expressed or misinterpreted because there are hearing and cognition impairments and many comorbidities. The febrile response may be relatively impaired, and fever without a source is quite frequent in this setting. And there may be limitations in resources to support an appropriate clinical assessment of the resident. For example, there may not be an advanced licensed practitioner on site to evaluate a fever in a resident. Evidence-based recommendations on the use of antimicrobials in long-term care residents are also limited. When there are recommendations, they are often based on clinical criteria targeted for younger populations with less complex problems, and optimal treatment regimens have not been well defined. The Centers for Disease Control and Prevention has developed the core elements for antibiotic stewardship in nursing homes to provide guidance. This chart shows an antimicrobial stewardship strategy hierarchy for use in long-term care. At the bottom of the chart are the least intrusive strategies, and at the top of the chart, the most intrusive. Passive monitoring includes measuring types and quantities of antibiotics used and understanding the presence of antimicrobial resistant organisms in the facility based on laboratory data. These activities may be implemented by a non-pharmacist, non-ID trained healthcare provider. So the suggestion is that passive monitoring can occur in any long-term care facility. Education is the next strategy that is suggested. That may take a little more time and effort in organizing a group of healthcare providers and providing them with appropriate education on improving antimicrobial use. The front-end passive approach is essentially limiting the types of antibiotics that are available in the facility, essentially implementing a formulary based on facility-specific susceptibility patterns. And then there is the more active front-end approach, which is requiring pre-authorization of antibiotics based upon predetermined criteria. Lastly, the most intrusive strategy is post-prescriptive review and feedback, when a team or expert antimicrobial prescribers provide feedback to the primary prescriber on their choice of antibiotics. So how do you select the cases for review? Selection criteria should be tailored to the problems in the facility and may include targeting residents on high-use agents, double coverage of anaerobes, or optimizing management of one infectious syndrome. The syndromic approach is one option, which I believe is quite useful in the long-term care setting, such as focusing on asymptomatic bacteria. Asymptomatic bacteria is defined as positive urine cultures in the absence of clinical signs and symptoms. Treatment for asymptomatic bacteria is indicated in pregnancy and after the genitourinary tract is manipulated only. However, multiple treatments are often given for asymptomatic bacteria in the elderly. Trial after trial have shown that there is no real benefit from treating patients with asymptomatic bacteria, as therapy does not decrease the occurrence of symptomatic infection or chronic symptoms, nor alter mortality. And a major consequence of treating patients with antibiotics for asymptomatic bacteria is unnecessary adverse drug effects and colonization with multi-drug resistant organisms. 5 to 50% of elderly patients in long-term care facilities have bacteriuria, and over 90% of elderly with bacteriuria have pyuria. There is no evidence of poor clinical outcomes for patients with high levels of pyuria. In fact, some individuals have levels of pyuria greater than 1,000 white blood cells per millimeter cubed of urine, persisting for months or years. Asymptomatic bacteria, with or without pyuria, should not be treated. In the elderly or residents of long-term care facilities with asymptomatic bacteria, we suggest removal of the indwelling catheter and replacing it with a straight or condom catheter, along with other prevention measures. This study looked at an educational intervention targeting the diagnosis and treatment of asymptomatic bacteria. Study investigators educated nurses on when to send a urine culture and doctors on asymptomatic bacteria and when it was appropriate to treat a urinary tract infection. This educational intervention was effective in decreasing total urine culture sent, decreasing inappropriate cultures, and decreasing number of residents treated for asymptomatic bacteria. Another study that I was involved with implemented a formal antibiotic stewardship program in 3 community long-term care facilities, utilizing post-prescriptive review and feedback with an ID pharmacist and an ID physician. Qualitatively, we found urinary catheters were quite uncommon. Residents rarely had signs and symptoms consistent with UTI, and empiric therapy was rarely used. There was a lot of pressure from nurses and families to send urinalyses and urine cultures for soft indications, even if the physician did not want to test. There was also significant pressure to treat positive cultures regardless of symptoms, which perpetuated treatment of asymptomatic bacteria. Antibiotic use in this study was most often inappropriate and only indicated in 18% of the cases evaluated. In summary, antibiotic stewardship programs are essential in long-term care facilities because there is a high rate of resistant organisms in this setting, variable infection control oversight, and unnecessary utilization of antimicrobials. CMS has established regulatory guidance to prioritize the development of antibiotic stewardship programs in long-term care facilities. However, implementation of antibiotic stewardship programs in long-term care facilities is obviously quite difficult, given the elderly population and their complexities with clinical assessment and diagnosis, as well as limited treatment guideline availability. The syndromic approach may be used as low-hanging fruit to target syndromes such as pneumonia or UTI. Educational strategies have demonstrated utility, but must include nurses, residents, and their families. ASP interventions must be tailored to the specific environment. One size does not fit all, especially in long-term care facilities. Our recommendations are that acute care and long-term care settings should partner together and improve interfacility communication and share resources such as ID expertise, infection control, and pharmacy expertise. The goal should be a standardized regional approach to antimicrobial stewardship implementation and infection control, because that strategy will be the most beneficial for our patients and residents.
End-of-life care is an emerging field and an important but often overlooked topic to consider in the context of antimicrobial stewardship. When I talk about end of life, I'm targeting the final weeks, days, hours in a person's life. I'm not focusing on patients with a terminal condition who are still doing well and are expected to remain functional with good quality of life. What is end-of-life care? There's a general lack of definitional clarity related to several concepts and terms. Terms like palliative care, end-of-life care, and hospice care are often used interchangeably, but there are important distinctions that need to be clarified both to patients, their families, as well as clinicians. Palliative care is defined simply as patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. Palliation is the stated goal. Again, the focus is on symptom management, especially pain management, not diagnostics, not invasive procedures, not trying to achieve cure. The physical symptoms at the end of life are numerous, and these might include weakness and fatigue, anorexia and cachexia, pain, nausea and vomiting, constipation, confusion, dyspnea, insomnia. It's also interesting that several of these symptoms are side effects that are associated with antimicrobial use. This is an integrated model of palliative care adapted from the World Health Organization. As you can see, early on, when patients are healthy, the focus is generally on prevention. Over time, as illness develops, there is a balance both between curative, life-prolonging care and palliative care. As disease progresses, that balance can shift towards palliative care. In terms of infections, it's not a surprise that patients at the end of life are at increased risk of infection due both to underlying disease as well as disease therapies. Often these patients can have nutritional reserves that are poor. The threshold to treat possible infection is often quite low, and aggressive management with antimicrobials is frequently pursued, at times when the overall prognosis is quite poor. So how often are antimicrobials used at the end of life? My colleagues and I reviewed all patients, most with very advanced disease, seen by the Palliative Care Service at the University of Michigan during a 5-month period in 2008. We found that about half, 70 of the 131, were receiving antibiotics at the time of initial palliative care consultation. Therapy was empiric in more than half, with respiratory infection and urinary tract infection being the most common indications. Piperacillin and tazobactam accounted for 37% of antibiotics administered, and this use was empiric in 85% of the cases. Vancomycin was given to a third of patients, 3/4 of whom did not have a clear microbiologic indication. Patients managed outside the ICU received antibiotics as frequently as those in the ICU. Overall, our results suggested that broad-spectrum antibiotics, almost all empiric, were being used frequently in hospitalized patients near the end of life. We published a follow-up study that examined antimicrobial use at the end of life among hospitalized patients with advanced cancer by reviewing the records of all patients who died of cancer while hospitalized at the University of Michigan Health System from 2004 to 2007. Among a study population of 145 patients, 26, or 87%, received antibiotics for a mean duration of 12.5 days. Of the 126 patients who got antibiotics, 88, or 70%, had clinical findings suggestive of infection, although once again, therapy in more than half was empiric. 72% received vancomycin, but only 15% of these patients had a clear microbiologic indication. Other antibiotics used included piperacillin and tazobactam, 64%, fluoroquinolones, 65%, cefepime, 24%, and aminoglycosides, 20%. C. difficile complicated 6% of admissions. One of the more remarkable things was that antibiotics were continued in 1/3 of patients who were placed on comfort care. While overall 45% of patients had antibiotic discontinued before death, this occurred on average less than 1 day prior to death. Based on these observations, we concluded that administration of broad-spectrum antibiotics is frequent, even less than 1 day prior to death. Our results suggested significant empiric use of broad-spectrum agents among hospitalized patients with advanced cancer, even after transition to comfort care. These two studies raised a number of questions. Although we tend to think of antibiotic use as part of usual necessary care in the medical surgical environment, the decision to use or not use antibiotics at the end of life is based on additional factors. Perhaps clinicians feel compelled to offer antimicrobial therapy for possible infection. The reasons for continuing antibiotics, especially once the goals of care had clearly transitioned, is less clear. So does antibiotic use at the end of life provide benefits? In order to answer this question, I'd like to look at some of the dementia literature. The next study is a wonderful study done by Erica D'Agata and Susan Mitchell, and it was published in 2008. They examined patterns of antimicrobial use among 214 nursing home residents with advanced dementia. During the time of the study, 2/3 of these patients with very severe cognitive impairment received at least one course of an antibiotic. The mean number per resident was an impressive 4 courses, and a mean of 53 days of antibiotic therapy for 1,000 resident days was recorded. The most common agents were quinolones in 38% and third-generation cephalosporins in 15%, with the primary indications being pneumonia and urinary tract infection. This is a graph that illustrates the patterns of antimicrobial use during the final 8 weeks of patients' lives. As you can see, as patients approach death, the portion of those receiving at least one antimicrobial increased significantly. Besides an increase in the number of courses of antibiotics closer to the time of death, there was also a statistically significant increase in the diagnosis of respiratory infection as an indication for use. In terms of the study's main conclusions, the authors reported that the number of antimicrobials prescribed and the days of therapy per 1,000 days all increased significantly as subjects approached death, especially during the final 2 weeks. Some of the same authors published another study that examined survival and comfort after treatment of pneumonia in patients with advanced dementia who were followed for 18 months or until the time of death. Of the 323 patients included, 133, or 41%, experienced 225 episodes of suspected pneumonia. This was called suspected because there was no chest x-ray performed in 23%. Antibiotics were given to 91%, with administration by mouth in 55%. The authors used standardized scales to assess symptoms and comfort. Antimicrobial administration by any route was associated with lower mortality compared to no antibiotic, and survival at 90 days among those not given an antibiotic was 33%, while among those with oral treatment, 64% were alive, as were 57 and 61% of those given an antibiotic by intramuscular injection intravenously, respectively. The average adjusted increase in survival time associated with antibiotic administration was 270 days compared to untreated episodes. However, the unadjusted comfort scores were highest for episodes that were not treated with antibiotic agents, and patients had progressively lower scores. In other words, authors observed worse comfort in association with increasingly aggressive care. So in terms of conclusions, antimicrobial agents were commonly prescribed among patients with advanced dementia as well as pneumonia. Among those who were treated, survival was improved on average by 9 months. Oral antibiotics were as effective as intramuscular and IV antibiotics in terms of survival. Among those who received treatment, those patients had lower comfort levels compared to those who received no treatment, and discomfort appeared to increase with more aggressive treatment modalities. The authors offer the following practical clinical guidance. If the goal is to prolong survival, even if discomfort is increased, consider limiting therapy to oral or IM modalities, since the benefits appear to be similar. However, if the primary goal is comfort, then antimicrobials should be withheld and palliation provided. The ethics surrounding end-of-life anti-infective use is an important consideration. Number one, giving antimicrobials at the end of life can delay a patient's transition to hospice. More importantly, patients and families may focus on minor ailments and perhaps even be given false hope and be distracted from important overall goals. Number two, antibiotics can prolong the dying process. It's an interesting way to look at it. By treating infection, you may, in fact, be extending suffering. Prescribing regimens incongruent with a short life expectancy and goals of care can increase the reservoir of resistance pathogens and place unreasonable costs on a capitated hospice system. Again, we see that sometimes clinically, where patients are ready to transition to hospice care. However, they remain on antibiotic agents, which cost a lot of money, have a lot of side effects, and require intensive monitoring. So how do we translate this into clinical practice? Clinicians often overlook antimicrobial use when addressing other aspects of end-of-life care. So obviously, there are some enormous barriers to change in this area. Since it requires a whole new way of thinking, not just for clinicians, but also patients and their family, current evidence does not support the notion that antibiotics uniformly provide comfort. Now, that said, antibiotics are likely more effective in providing comfort for some symptoms than others. And a few examples are listed here: dysuria with urinary tract infection, dysphagia from thrush, diarrhea in the setting of C. difficile. But for pneumonia, perhaps opioids are a better approach to symptom management. The potential burdens and benefits of treatment with antimicrobials should be carefully assessed in each individual, especially when palliation is a stated goal. And again, going back to the beginning of my presentation, I'm talking about patients who are really in the final few days of their life. Some clinicians may feel uncomfortable even discussing the notion of withholding antibiotics for fear that this may be unethical. Others may believe wrongly that a course of antibiotics is innocuous. But we should keep in mind that antibiotics at the end of life, especially empiric use with IV agents, may distract from the focus of care and delay transition to hospice or even discharge from the acute care setting. In terms of implementing changes in our practice, we can start by reaching out to our colleagues. Start a discussion. Educational sessions are a good place to begin. Consider making antimicrobial use part of advanced care planning and clearly acknowledge futility. More often than not, patients would likely indicate that they would, in fact, want a trial of antibiotics. However, what about not offering antibiotics when the clinical scenario is futile? We have clinicians asking patients and families whether they want this or that, and in essence, asking families and patients to make medical decisions instead of having truly informed, shared decision-making, where physicians are giving true guidance and medical recommendations. And again, this should be part of our goals of care discussion. If antimicrobials are used, try to move to oral or even IM formulations if possible. Be mindful of associated side effects and ask yourself and ask the patients if treatment is contributing to the overall goals of care or simply offering symbolic value. With that, I'm going to end, and I realize I may be leaving you with more questions than answers, but I hope that you will think about end-of-life care as an area for stewardship interventions.
In today's session, we'll be talking about expanding stewardship programs into the small community hospital setting. The first question we should ask ourselves is, how does antibiotic use compare in small hospitals compared to large hospitals? These data come from Intermountain Healthcare. What we're looking here are at 19 of Intermountain's hospitals. On the right-hand side in the light gray are large community hospitals that have greater than 200 beds. On the left side, in the dark gray, we see our 15 small community hospitals. The height of the bar represents the antibiotic use rates in days of therapy per 1,000 patient days. We're looking at 3-year median antibiotic use rates. And what you can see is that a number of the small community hospitals on the left have very similar rates to the large community hospitals on the right. We also see considerable variability in our small community hospitals. The red star on the right represents Intermountain Medical Center, our largest academic medical center in the system. How many small hospitals now have stewardship programs? The CDC provides us these data from the NHSN annual survey. They asked hospitals how many of the CDC core elements of stewardship were active in their hospitals. And what we can see from these graphs is that the smaller the hospital, the more likely you are to not have a stewardship program that has all 7 core elements. In fact, of the hospitals that had 0 to 50 beds, only 31% of those facilities had antibiotic stewardship programs that met all of the core elements of the CDC. However, in hospitals that had greater than 200 beds, 66% of those hospitals met all core elements. So we know that there are a large number of U.S. hospitals that are small, with less than 200 beds. Many of them have similar antibiotic use rates compared to large hospitals. Most of these are without stewardship programs, and there is very few studies of stewardship in these settings. However, all of these hospitals will be required to have stewardship programs under Joint Commission regulation and forthcoming CMS conditions of participation. There are multiple similarities and differences as it pertains to development and sustainability of a stewardship program in small and large hospitals. We'll talk about bed size and location, constructing a stewardship team, patients and infections, drug resistance and microbiology lab, data collection, and cost. By definition, small community hospitals have less than 200 beds, and small hospitals are many times located in very rural settings. However, some may be quite urban. So what does this mean for stewardship program development? The rural hospitals, oftentimes due to their remote status, have no access to specialty care. This includes infectious disease providers, but will also include subspecialty surgical and medical specialties. Due to the small number of beds, significantly less time is needed for day-to-day antibiotic stewardship review. A 50-bed hospital, for example, may have only 25 patients on antibiotics, and most of these patients are likely on antibiotics for common conditions such as pneumonia, urinary tract infection, and skin infections. Given that most of these patients have common conditions, the time required for stewardship interventions is likely to be much less than large hospitals. Constructing a team. There are similarities between small and large hospitals when it comes to constructing a team. A local leader is very important. Multidisciplinary teams are incredibly important to engage clinicians. The engagement of both the antibiotic stewardship staff and the clinicians is critical. Staff capacity is limited in both small and large hospitals. However, in small hospitals, ID physicians and pharmacists are rare, where in large hospitals, ID physicians are common. So what does this mean for small hospitals? Is that we must be cognizant of small community hospitals, clinicians, and their other duties that they perform for their hospitals. Many times, these clinicians will be on multiple committees and have multiple clinical commitments. It is therefore recommended to combine antibiotic stewardship meetings and committees into other standing committees, such as pharmacy and therapeutics or medical executive councils. ID clinicians are often rare in these instances. However, they should be actively involved if possible. To involve ID clinicians, one must be creative. We are seeing more small hospitals utilize tele-infectious disease and stewardship programs to engage ID clinicians and using external ID consultants under contracts. If an ID physician is unable to be used in developing the team, appropriate training must be obtained by the local physicians and pharmacists to run the team. Patients and infections. In small community hospitals, the patients are typically less complex, and they typically have more standard infections such as pneumonia, urine infections, and skin infections. The more complex, complicated patients many times are transferred to large community hospitals. In terms of stewardship, this means that focusing on core syndromes in small hospitals, such as pneumonia, urine infections, and skin infections, will capture the vast majority of patients on antibiotics. It also will take generally less time to review patients due to the less complex nature. However, there are still plenty of very sick patients that need attention quickly in small community hospitals. Drug resistance and laboratory limitations. There are significant differences between small and large hospitals when it comes to drug resistance and microbiology limitations. In small hospitals, there's often decreased antimicrobial resistance in terms of MRSA, vancomycin-resistant enterococcus, and drug-resistant gram-negatives. Small hospitals often utilize and rely more on off-site microbiology labs as compared to large facilities. In addition, small hospitals have a decreased number of bacterial isolates for the development of antibiograms. And small hospitals, given their reliance on off-site microbiology labs, utilize rapid tests often much less than the larger facilities. So what does this mean for stewardship? Given the decreased antibiotic resistance in small hospitals, the stewardship program should match antibiotic restriction policies to the microbiology of their facility that they see. If the facility does not see large numbers of drug-resistant bacteria, antibiotics targeting these agents should be restricted. Given the few numbers of bacterial isolates that will populate an antibiogram, it is critical that antibiotic stewardship programs promote the obtaining of appropriate clinical cultures. Many small community hospitals have partnered with other regional facilities to develop community-based antibiograms to add depth to their antibiogram and provide the appropriate power. It should also be noted that given the off-site nature of the microbiology labs and the few rapid diagnostic tests that are available, antibiotic de-escalation is often delayed due to long turnaround times obtained at small community hospitals. This means that empiric therapy needs to be appropriate, and setting clear care process models to define appropriate initial therapy is critical. Data collection and analysis. In small hospitals, just like in large hospitals, many stewardship programs are uncertain what to measure in terms of antibiotic stewardship programs. However, in small hospitals, there's often a lack of access to data due to the lack of sophisticated IT departments in order to pull electronic data. In addition, small hospitals often lack infectious disease provider to interpret the data and put it into the national context. Our recommendation is that the small hospitals obtain antibiotic consumption data in a consistent manner. Most often, small hospitals rely on defined daily doses, as this is a metric that is easier to obtain than days of therapy, which requires individual patient-level data. If possible, small hospitals should utilize their healthcare system or network to obtain antibiotic usage data. That being said, chart reviews to assess antibiotic appropriateness is often easier at small community hospitals due to the few number of patients, and appropriateness measures can be obtained on an ongoing basis to assess antibiotic prescribing in small hospitals. In the end, however, it is essential that all stewardship programs measure something and do it in a consistent and sustainable manner. And finally, cost. As in large hospitals, it is equally as important in small hospitals to have administrative support of the stewardship program. The difference, however, is that in small hospitals, it often does not require hiring a full-time position to develop a stewardship program, whereas in large hospitals, it is often required to hire 1 to 3 additional trained ID personnel to develop their stewardship program. A business case must be developed and well thought through for small hospitals to ensure that time is protected for the staff to do stewardship activities. Dedicated time is required to establish an antibiotic stewardship program in both small and large facilities. In small hospitals, antibiotic stewardship program must be made a priority, and dedicated time must be given to the appropriate staff. What we've done is we developed the infectious disease telehealth program. This telehealth program provides infectious disease services for our 16 community and rural hospitals in Utah and southern Idaho. We provide inpatient, face-to-face ID consultation via in-room camera and perform full infectious disease consultation telehealth visits. We also offer telephone consultation and advice for inpatient, outpatient, emergency department, acute care clinics, and provide this service 24 hours a day, 7 days a week via an infectious disease hotline. And finally, our infectious disease telehealth program staff supports the antibiotic stewardship efforts at all of these 16 community hospitals. We have an infectious disease pharmacist that monitors real-time alerts and alerts local clinicians and pharmacists with interventions. In addition, our infectious disease telehealth program staff monitors and mentors local stewardship programs and provides them central guidance for projects and data and education. Here is an example of our central data that we provide to all of our 16 small community hospital stewardship programs. What you see here is an antibiotic usage dashboard that we provide on a monthly basis that shows the antibiotic usage rates for all antibiotics and then also CDC-defined categories on a monthly basis. These dashboards are fully transparent, and one hospital can see the antibiotic usage rates of other hospitals. In conclusion, small community hospitals are different than large hospitals in many ways, and implementing an antibiotic stewardship program will also be different. One size does not fit all. Utilizing a collaborative approach and tailoring stewardship activities to the needs of small hospitals and the resources available can lead to successful programs. However, new models of stewardship will need to be evaluated to meet the needs of small hospitals. Thank you.
Antimicrobial resistance from a global perspective. Along with clean water, sanitation and vaccines, antimicrobials were responsible for the vast improvements in health and life expectancy over the past century. However, those important gains are at risk due to the widespread misuse and overuse of these life-saving drugs. At the same time, many people, especially in low and middle-income countries, are still struggling to gain access to high-quality antimicrobials to treat infections. Antimicrobial resistance, or AMR, is a global issue. The lack of action in one country can undermine progress in another. Therefore, responding to AMR is a global responsibility, relying on accountability and solidarity among countries. This presentation will give you an overview of how a global momentum to address AMR was built up and how the World Health Organization and partners are working on bringing about change. AMR is recognized as one of the greatest threats to human health worldwide. Antimicrobial resistant microbes can be found in people, animals, food, and the environment. They can spread between people and animals, from person to person, from country to country. Poor infection control, inadequate sanitary conditions, and inappropriate food handling encourage the spread of antimicrobial resistance. In May 2016, a review on AMR was published in which it is estimated that, unless action is taken, the death toll from AMR could increase to 10 million lives each year by 2050. This means that every 3 seconds a person will die because of a resistant infection. In economic terms, it means that every year an economy the size of the United Kingdom will be removed from the global economic output. In 2014, WHO published a global report on the surveillance of antimicrobial resistance. Based on data obtained from 129 member states around the world, the most important findings of the report revealed very high rates of resistance observed in all WHO regions, highlighting the global nature of the problem. That there are still many gaps in knowledge and information on pathogens that are of major public health importance, and that key tools to tackle AMR, for example surveillance systems, do not exist in many countries. In 2015, WHO published another report, providing a global overview of the capacity of countries to respond to the threat of AMR. The most important findings of this report include widespread over-the-counter sales of antimicrobial medicines, even in some countries that have a policy in place, lacking standard treatment guidelines, lacking infection prevention and control programs, low public awareness, and in addition, the report highlighted the issue of weak linkages between relevant sectors, low levels of coordination and leadership, and that only 25% of the 133 countries that provided information for the report have a comprehensive action plan for AMR in place. So let us look at the broader context of AMR. Antimicrobials are non-renewable resources, and the current benefits of antimicrobials must be balanced against their use leading to resistance. Such services as major surgeries, cancer treatments, and treatment of pneumonia will be compromised, endangering all the progress made in modern medicine and undermining the function of health systems as we know them. Increasing expectations and demands of patients lead to the ethical dilemma of excess versus excess. Where some populations lack access to vital antimicrobials, easy access in other populations lead to excessive use and misuse of these precious medicines. Financial incentives that link medicine sales with health provider revenues should be abandoned. If current practices are continued, the societal impact of our actions will compromise the right of future generations to effective treatment options. So let's look at the specific challenges for low and middle income countries and why they are particularly at risk. Low and middle income countries usually have a high burden of infectious diseases, a large proportion of which could be caused by resistant pathogens. This burden is maintained through poor infection prevention and control practices and a generally low quality of care. There often is weak control of prescription or enforcement of legislation against over-the-counter sales, as well as the issues of access versus excess. There may be issues with quality of drugs and diagnostics, including counterfeit or substandard medicines. And generally there is a low service delivery capacity, including diagnostic support by laboratories. All these factors considered, the achievement of several Sustainable Development Goals will depend upon access to and availability of affordable antimicrobials that work. Mortality and morbidity in vulnerable populations of newborns, children and women will escalate if AMR is not effectively contained. In this sense, AMR should be considered a development issue and must be addressed accordingly throughout the world. While there is currently only limited reliable knowledge about the availability of antimicrobial medicines, including antibiotics, around the world, it is generally accepted that the current antibiotic consumption is highest in high-income countries, but the growth in antibiotic consumption is highest in low and middle-income countries. In Europe, primary care accounts for 80 to 90% of all antibiotic prescriptions, mostly for respiratory tract infections. Antibiotics are also widely utilized in other sectors. For instance, approximately 80% of antibiotics in the United States are consumed in agriculture, farming, and aquaculture. Antimicrobial resistance is a complex problem that affects all of society and is driven by many interconnected factors. Single, isolated interventions have shown to have limited impact. Coordinated action is required to minimize the emergence and spread of antimicrobial resistance. Although there are many activities, campaigns, policies and protocols around the world, these need to be coordinated to avoid duplication of work and important gaps unattended. AMR has been known to be an important health issue for several decades, but as a slow developing threat, it was often overshadowed by more acute and visible health issues such as SARS, avian influenza and Ebola. However, the unprecedented momentum around antimicrobial resistance that we witness around the globe today can be largely accredited to a very successful World Health Day in 2011. The day did not only draw attention again to the issue of antimicrobial resistance, but managed effectively to instill a sense of urgency and severity through the campaign slogan, "No action today, no cure tomorrow." Later that same year, all 53 member states of the WHO European region adopted a regional strategic action plan on antibiotic resistance. As awareness continued to grow, the Global Action Plan on Antimicrobial Resistance was adopted by the World Health Assembly in 2015. Later that year, AMR also appeared high on the G7 agenda, ensuring support of these powerful countries. In 2016, AMR was discussed during the United Nations General Assembly as only the fourth health issue ever to be discussed at this high level. In 2017, AMR is high on the agenda of the G20 meeting, which will further strengthen AMR on the global health agenda and affirm WHO's leadership in addressing AMR globally. The goal of the Global Action Plan on Antimicrobial Resistance is to ensure, for as long as possible, continuity of successful treatment and prevention of infectious diseases with effective and safe medicines that are quality assured, used in a responsible way, and accessible to all who need them. The action plan has 5 strategic objectives: improving awareness and understanding, which includes education of human and animal health professionals; strengthening knowledge and evidence-based, which includes strengthening national AMR surveillance systems; reduce incidence of infection, which includes implementing infection prevention and control programs as well as vaccination programs; optimize use of antimicrobial medicines, which includes measuring the use of antimicrobials; and develop the economic case for sustainable development that takes account of the needs of all countries and increase investment in new medicines, diagnostic tools, vaccines, and other interventions. WHO is working closely with FAO and OIE in a One Health approach to promote best practices to avoid the emergence and spread of antimicrobial resistance, including optimal use of antimicrobials in both humans and animals. The Global Action Plan contains a framework for action, which tabulates the actions that Member States, the Secretariat, and international and national partners need to take in order to attain the goal and meet the objectives of the Global Action Plan. By committing to the Global Action Plan, all countries were urged to have a national AMR action plan in place by May 2017. And although not all countries were able to reach this goal within 2 years, most countries are developing their national action plans, and many activities have been launched all over the world. At the national level, WHO support governments' national action plan development, implementation, and monitoring. WHO's work at the technical level involves strengthening the health workforce by building capacity for infection prevention and control, antimicrobial stewardship, antimicrobial resistance and use surveillance, and by supporting laboratories to detect and report resistant pathogens. Next to supporting countries individually, important work is being done at the global level. In the next slides, a few key areas are highlighted. WHO and partners have been building regional surveillance networks to stimulate and strengthen national surveillance systems. Examples of such regional networks include RELAVRA in the Americas and the CESAR network in Central Asia and the Eastern European part of the European region. The European Centre for Disease Prevention and Control, ECDC, manages regional networks on AMR, antimicrobial use, and healthcare-associated infections for countries of the European Union. In October 2015, WHO launched the Global Antimicrobial Resistance Surveillance System, or GLAS, to foster standardized AMR surveillance globally. Surveillance of antimicrobial use and resistance is important for building the evidence base for national policy making, advocacy, implementing interventions, and monitoring their effect. Prevention is better than cure. High vaccine coverage and effective infection prevention and control measures prevent infections that otherwise would require treatment and therefore help preserve antimicrobials. Improved management of the use of antimicrobials in food animals, particularly reducing those critically important for human medicine, is an important step towards preserving the benefits of antimicrobials for people. WHO has ranked antimicrobials according to their relative importance in human medicine, in order to help clinicians, regulatory agencies, policymakers and other stakeholders to preserve the effectiveness of currently available antimicrobials. Essential medicines are those that satisfy the priority healthcare needs of the population. They are selected with due regard to public health relevance, evidence on efficacy and safety, and comparative cost-effectiveness. Essential medicines are intended to be available within the context of functioning health systems at all times in adequate amounts, in the appropriate dosage forms, with assured quality and adequate information, and at a price the individual and the community can afford. The newest edition of the Essential Medicines list will give due attention to resistance patterns, with the attempt to reduce and contain resistance for high-priority antimicrobial medicines and to avoid empiric use of antimicrobials with widespread resistance. WHO was asked by member states to develop a global priority pathogens list of antibiotic-resistant bacteria to help prioritize research and development of new and effective antibiotic treatments. It should be noted that Mycobacterium tuberculosis, the bacterium responsible for human TB, was not included in the scope of the prioritization of previously unrecognized health threats because there is already consensus that TB is a top priority for R&D for new antibiotics. The most critical group of all includes multi-drug resistant bacteria that pose a particular threat in hospitals, nursing homes, and among patients whose care requires devices such as ventilators and blood catheters. They can cause severe and often deadly infections such as bloodstream infections and pneumonia. These bacteria have become resistant to a large number of antibiotics, including carbapenems and third-generation cephalosporins. And while more R&D is vital, more is needed to solve the problem. To address resistance, there must also be better prevention of infections and appropriate use of existing antimicrobials in humans and animals, as well as rational use of new antimicrobials that may be developed in the future. The first objective of the Global Action Plan on AMR is to improve awareness and understanding of antimicrobial resistance through effective communication, education, and training. To help achieve this objective, WHO launched the Antibiotics Handle with Care campaign during the first World Antibiotic Awareness Week in November 2015, working closely with FAO and OIE. The Awareness Week has been well received and campaigns have been launched around the world during the week. The campaign includes call for action for all levels of society, including health professionals. WHO and many technical partners support capacity building of healthcare professionals, including frontline clinicians, epidemiologists, and microbiologists to improve patient care. Their efforts also help to build AMR surveillance to gain an overview of the resistance patterns to support treatment decisions. Healthcare professionals need to become antimicrobial stewards, who consider not only the individual effect of prescribing medicines, but also realizing the societal impact of the chosen treatment. This is why clinicians are such an important part of the solution, and the reason why they are targeted by campaigns and capacity building interventions. National action plans on AMR often involve reforms of educational curricula for under- and postgraduate healthcare professionals, licensing requirements, and other interventions aimed at clinicians. Multifaceted, comprehensive interventions to reduce the overuse of antimicrobial medicines have been found to be effective and better than single initiatives. Globally, there is consensus that interventions should encompass the enforcement of the policy of prohibiting the over-the-counter sales of antimicrobials, the use of antimicrobial stewardship programs, participation of clinicians in audits, the utilization of rapid point-of-care tests, the promotion of delayed antimicrobial medicines prescribing strategies, the enhancement of communication skills with patients, and enhanced professional collaboration in interdisciplinary teams. Everybody has a role to play to help control antimicrobial resistance, or in other words, nobody is exempt from the problem, nor from playing a part in the solution. Thank you for your attention.
Leland Stanford Jr. died in 1884 of typhoid fever. He died because the age of antibiotics remained a half-century into the future. In 1941, Albert Alexander was almost cured by an antibiotic, but he fell victim to a more contemporary problem, a drug shortage. When the few grams of penicillin available ran out, he died. The subsequent development of novel antibiotics became a raging success story, but that success may be devolving into failure as the commercial interest of many pharmaceutical companies has shifted away from antibiotics and toward more lucrative classes of drugs. Alexander Fleming's exhortation at the time of his receipt of the 1945 Nobel Prize in Physiology and Medicine, in which he warned about the development of bacterial resistance to penicillin resulting from its misuse, seemed for a time to be an undue fear. That somewhat innocent time, however, has passed as the problem of rampant antibiotic resistance in the face of limited development of new antibiotics is finally being recognized as a critical public health issue. At a congressional briefing in September 2013, representatives of the Infectious Disease Society of America, the Centers for Disease Control and Prevention, and the Pew Charitable Trust spoke to Congress of the need for them to take a number of actions to combat the problem of antibiotic resistance. They highlighted the comprehensive Centers for Disease Control report that provided a minimal estimate of more than 2 million infections and 23,000 deaths due to multi-drug resistant organisms annually in the United States, numbers which the CDC, in fact, believe are likely to represent significant underestimates. Furthermore, these estimates do not include at least 250,000 cases and 14,000 deaths due to Clostridium difficile infection, a problem related to antibiotic misuse. In their report, CDC recommends several core actions aimed at stopping the spread of antibiotic resistance. Among these is the improvement in the way antibiotics are used. that is the same goal as that of antimicrobial stewardship. An effective antimicrobial stewardship program must be based on the clinical science of antibiotic use and the application of principles that aim at achieving the optimum balance in patient care, that is, both for the individual patient and for every patient to follow. We hope this course has provided the foundation that you will build on as you develop your stewardship practice or program. Using antimicrobials wisely is not a choice, it is the responsibility of every clinician and every patient. We all must embrace our roles as the guardians of antibiotics to preserve this precious, non-renewable resource and medical care as we now know it.